Hello. Hello. Happy Friday, all. Welcome to Virtual Morning Report. Great to see a lot of familiar faces. Ori, hello, hello. Soon to be making your trek over to San Francisco, unless you're already here.
I move on Wednesday.
You move on Wednesday? When do you get here?
I move there Wednesday, and then I start on the 21st at the VA. Actually,
What? What
are
rotation?
you on service?
Yes.
Oh, that's awesome.
Yeah, wait, what? Are you on the wards or where?
I'm on the wards. I'm on Team 5.
It may be the best team. We'll see.
Sounds great. I can't wait.
What part of the city are you staying in?
So we got a place in Forest Knolls.
Oh, okay.
Yeah.
You're welcome to come hang anytime. You have a
That would
home
be
in
awesome.
You have a home in Japantown. I would put out my address, but I've been getting these scam calls all morning long, which is great. Apparently, somebody signed up for healthcare with my number. Her name is Sandra. Good morning. Marcella, hi. Thank you for having your video on. It's so great to see you all. I'm talking a lot to compensate for my sadness. That stems in large part because I'm going solo again, which is counter to the words we said yesterday with a wonderful VMR session led by Priyanka and team about why when you don't have to go solo, you go solo. But Reza is back on service, and as he likes to do, 1000% committed to his patients. He ignores my texts. I haven't talked to him for 14 hours, which is a long time. But as a special treat, there are two things to announce. One, it's Andrea's birthday. So happy birthday. Join me in singing out loud to Andrea. I can't sing for the life of me. But yes, Andrea is a beloved member of the CP Solvers who currently leads the Instagram effort, but has done almost everything you can imagine. She's put together really cool videos for us to promote our work and actually began her journey with the CP Solvers on Virtual Morning Report and continues to make a prominent presence here. And if you follow her on Twitter, you'll notice that she literally does almost everything under the sun career-wise. Every time I talk to her, she has something new and cool that's going on. And anytime you have a hard time remembering all the things that somebody is doing, you know they're doing good. So happy birthday, Andrea. It's really, really nice to see you here.
Thank you so much, Ravi. I really enjoy being part of this family.
We love having you too, my friend. And the other surprise is that one of our very own has a challenge case for us. Sorry, I shouldn't eat with my mouth full. All right, Kirtan is here and has a doozy of a case prepared. All I know is the doozy of a case. I don't really know anything else about it, true to form. And I have to unfortunately tackle it without my academic soulmate. So without further ado, let's hear the brilliant mind of Kirtan take us through a case.
All right, good morning, everyone. Thank you for having me, giving me this opportunity to present the case. And I will start with the chief complaint. So the chief complaint is nausea, vomiting, and altered mental status. And Ravi, do you want me to stop or give you a bit of HPI too?
No, I think this is a great place to stop. And the truth is that we get plenty of exposure thinking about just this amount of information. It's not uncommon that you have access to the chief concern, either based on where you're working or how the conversation initially begins when you're getting sign out from another provider. And often the question is, well, what are your initial hypotheses when you hear this? And it's incredible what happens by default. What happens by default for most people is we assume that the syndrome is acute, even though we don't have a time course. And the reason most of us probably thought, oh, this is acute altered mental status, nausea and vomiting, is because the assumption that these things are so severe, somebody's confused or nauseous or vomiting, they're so debilitating that people would probably not take tremendous time to show up and ask for help. Like if you're confused, nauseous and vomiting, you need help quick. But it's not inconceivable when you take a deep breath and ask yourself, how sure am I that this is actually acute? The answer is, not 100% sure. There are a lot of chronic nausea and vomiting syndromes. There are a lot of chronic encephalopathy syndromes. So the assumption may be flawed. But the reason we assume acute is because the morbidity lies under the umbrella of acuity, and almost all things that are acute, if untreated, will become chronic. And so your goal is to take this and make it unacute and unchronic. And so the next question is, well, what are you going to use to allow yourself to begin to formulate hypotheses? And that's when you have to filter symptoms into diagnostically fruitful versus not. And nausea and vomiting is less diagnostically fruitful than encephalopathy. The reason that is nausea and vomiting reflects some trigger of the vagus nerve, which literally innervates your body from head to toe. So the localization of nausea and vomiting maps onto vagus nerve pathology, which maps onto anything from head to toe. You can have elevated intracranial pressure causing nausea and vomiting, and you can fracture your toe and cause nausea and vomiting. So that's one dimension. The other dimension is altered mental status. Now, altered mental status also has very little localizing value, honestly. How do we know that? Join me for the ride into acute altered mental status, where we deploy the MIST mnemonic: M for metabolic, I for infection, S for structural, and T for toxin. M, I, and T are all things outside the brain that cause brain problems. So in some ways, you can have a fracture of your toe cause a fat embolism, and that's why you're altered. So anything from head to toe literally can cause altered mental status. So the localization of this pathology is very nebulous. What progress can we make to actually get a better hold of where the disease state lies is probably in understanding accompanying features of the nausea and vomiting and accompanying features of the altered mental status. If the altered mental status is hyperacute, it's probably in the brain in the form of stroke, seizure, and less likely hypoglycemia. If the altered mental status is accompanied by two things, either signs of focal neurological disease like altered mental status and left arm weakness, or if the altered mental status is deep, it's much more likely to reside in the brain itself. So nausea and vomiting, if it comes with abdominal pain, that's focality. We'll see where that lands. Altered mental status, if it comes with either a focal neurological syndrome, or that if it's so deep and so severe, it is much more likely to live in the brain. It's no different, by the way, than when somebody has a creatinine of 15. I can guarantee you it's not pre-renal. A creatinine of 15 likely has resulted in problems within the kidney itself inherently. And so the depth of the encephalopathy is also a proxy, though not perfect, of the brain itself being diseased. So the clinician walking into a patient like this might be inclined to make the error of assuming that the altered mental status is driving the nausea and vomiting, because that is something that we can easily say, oh, elevated ICP, diffuse cerebral edema, brainstem stroke, all cause encephalopathy and nausea and vomiting, but that's incorrect. You have to step back and say anything from head to toe is fair game, because both the localization of nausea and vomiting and of encephalopathy is actually fairly diffuse. So stand back and maintain vigilance for anything from head to toe being possible, and pay particular attention to the company that the nausea and vomiting is featuring that may be hidden from you because the patient is too altered to tell you, or if you find focal neurological signs, or if you find the patient obtunded, the chances of something in the brain are fairly high. All right, Kirtan, back to you.
All right. Yes, so now giving you a bit of HPI, we have a 57-year-old lady who presented with the history of nausea, vomiting, and confusion for 3 days. She has been vomiting 3 to 4 times per day. The vomiting is unrelated to food intake. It contains the semi-ingested, semi-solid food particles. It is non-bilious, it is non-projectile, and there is no evidence of any visible blood in it. She also endorses anorexia, malaise, and fatigue since 1 month. And since yesterday, family members noticed some confusion and somnolence, prompting them to bring her to the emergency department today. And talking about the review of systems, she denies weight loss, fevers, chills, night sweats, cough, chest pain, dizziness, headache, diarrhea, or abdominal pain. So all of these were negative complaints or negative findings. And Ravi, do you want me to give past medical history and meds?
Yeah, why not? Let's do it.
Sure. So for the past medical history, she has hypertension for last 15 years. She has ischemic heart disease for last 3 years. And the last ejection fraction a year ago was 40%. She also has CKD for last 3 years. As for her medications, she is on losartan, amlodipine, and labetalol. Family history is non-significant. As for social history, she denies alcohol, tobacco, or illicit drug use, and no allergies. So that's the end of Ellicott number 2.
Fantastic. Thank you so much, my friend. So you know what we got is we got relative confirmation of our instinct, and our instinct usually is that somebody has these things that are fairly acute, and they certainly are. Does the study of the content that is being vomited help in some way, shape, or form? And the answer is yes and no. You always want to know whether anything coming out of a person is bloody or not, be it cough, urine, bowel movements, or even emesis. And the fact that it's non-bloody is helpful, that we don't have to temporize any potential for hemorrhagic shock. What is the value of it being semi-digested? It tells you that the content is really not making it far before it comes back up, and tells you that there's probably something going on in the upper GI tract. But that doesn't localize the pathology to the upper GI tract. And as really bad medication causing nausea and vomiting will propel the contents back up immediately after they make it into the stomach, because of the nausea that medication induces. So it doesn't tell you there's something wrong with the stomach or the duodenum itself. The tricky part is that we found that that there's actually been a background of symptoms for a month. So what do we make of anorexia and fatigue for a month? And does that give us more malleability in terms of the space-time continuum? And do we phrase this as an acute complication of a previously undiagnosed syndrome characterized by fatigue and malaise? And that's possible. I'll tell you that it's relatively unusual for a syndrome to go like this for a month and then boom, take off. Most people who have an explanation of sudden worsening because of a subacute syndrome typically get worse and worse and worse and worse and worse and worse till they present to care. So there's some intriguing possibility of saying, is what's been going on for the last month related to what's going on today? And the answer is we should be open to that possibility, but open to the fact that they're unrelated. And as we get more clarity on what's going on now, we'll be able to pin it back to what's maybe been going on before. But one thing that weakens the hypothesis is how abrupt this syndrome appears to be compared to how slowly progressive the anorexia and the fatigue have been. Now, if you told me that the anorexia and fatigue had been going on for 1 week and then boom, she's much worse, I'd buy that. But a month seems to put into question at least the default assumption that she's been unwell for a month. And she might have had something completely unrelated. But you know, the easy way of connecting what's been going on for a long time to what's going on today is the idea of threshold. If I roll this, if I have a table here, and if I roll a pen across this pretty long table, nothing will happen for about 10 seconds and then boom, the pen will fall off the table. So just because she really falls off a cliff, clinically speaking, right now doesn't mean that the pen has been rolling for a while. So how can that happen? A slowly progressive pericardial effusion over a few weeks becomes tamponade. As an example, an intracranial mass lesion grows enough just to cause uncal herniation a month later. You know, so things are possible that way, but usually they progress slowly and then the patient gets much worse as opposed to this boom, sudden worsening. We don't find any evidence of focal neurological findings in terms of focality as far as we know now. And the somnolence may be mild or severe. We'll have to wait for the exam to tell us, like, is this in the brain? Because it's very, very somnolent. And, you know, to be honest, and to tell you a little bit of CPS gamesmanship, as soon as I heard the ischemic heart disease, I was like, oh, how can the heart explain the brain issue? And, you know, concomitant coronary artery disease frequently accompanies concomitant cerebrovascular disease is one possibility. The heart being perfusion to the brain is another way, where there's a transient ischemic event from the heart resulting in hypoxic brain disease is also well described. Embolic disease from the heart to the brain is also something to think about. But a very probably under-recognized complication of heart disease and brain is the medications that we use for heart disease. And I was worried that this was a case that was starting to look like digoxin toxicity as soon as the words ischemic heart disease were mentioned, with nausea, vomiting, and encephalopathy. But the lack of digoxin being prescribed is one big ding against that hypothesis. But you have to remember that you can also get digoxin toxicity, not necessarily from medications, but also from plant-based glycosides, which this patient might be exposed to. So what did we learn here? Not much, honestly. We've learned that there might be a relevant history with regards to the heart, and I think we can reflect and take this reflection for you and refine it for yourself. What does it mean when somebody gets suddenly worse, but their symptoms have been going on for a month? Does it mean that the month-long symptoms are related to what's going on today? We heard the pluses and the minuses. The pluses are that something can build up for a month and then suddenly collapse like a pericardial effusion. But sometimes people have unrelated things that go on forever and their acute syndrome has nothing to do with it. And how we connect the dots really is by understanding what's going on now. So I'm really curious to lay eyes on this patient and look for how deep is the encephalopathy, is there focality? And I think the nausea vomiting exam is usually underwhelming. If the patient is not telling us of something, we usually won't find anything. And so the labs, I imagine, will be very, very helpful. All right, Kirtan, back to you.
All right. So since this patient was in the emergency department, we were not able to do a full comprehensive examination, but still we were able to do just enough to help us. So starting with the vitals, the temperature was normal. The heart rate was 46 beats per minute. The blood pressure was 70/40 millimeters of mercury. She was saturating at 93% on room air, and the respiratory rate was 25 breaths per minute. Now, talking about the general appearance of the patient, she appeared unwell and confused. For the abdominal examination, it was unremarkable, no evidence of tenderness, rigidity, or guarding. The bowel sounds were normal. As for the cardiovascular examination, the normal S1 and S2 were heard. Apart from bradycardia, the rhythm was regular. There was no evidence of any murmurs or pericardial knock. The JVP was not elevated. As for the pulmonary examination, there was evidence of bibasilar crackles, but it was like not super alarming or something, just a little bit of crackles. As for the extremities and the skin examination, there was evidence of 1+ pitting edema bilaterally up to the level of mid-shins. And then now coming to the neurological examination, for the mental status, the patient was disoriented to time and place, but she was oriented to person. The cranial nerve examination was normal. The motor strength was normal. The muscle bulk and tone along with the reflexes were normal. The plantar reflexes were downgoing bilaterally. The meningeal signs were absent. And as for the higher function examination, she was confused, but not super confused. And there was even evidence of short-term memory loss. But apart from that, she was able to recognize the family members, able to recognize the doctors. So that's how the examination was. And Ravi, do you want me to give some labs too?
Hey, there's so much to digest here, my friend. Can I ask you one question? I'm
Yes.
sorry if I missed it. There's a lot to process here. What was the jugular venous pulse or estimate of the JVP?
So it was estimated at around 6 centimeter.
Okay, all right. Very, very helpful. So, we have profound hypotension here. The blood pressure being 70/40 is very concerning. And I think that it's hard not to look at that and immediately act. And so what do you do when somebody has a blood pressure of 70/40? The first thing to recognize is perfusion is key to the brain. And it's totally okay to compromise the kidneys and the legs to protect the vein. So put this patient in Trendelenburg. How do we think about hypotension? The first step is to ask yourself, is this number real? And the easiest way to understand whether the body is being perfused is to study the things that the body communicates to the outside world. And it communicates through two ways, through the skin and through the brain. That's how we communicate with the world. So here we look at the skin exam, and the skin exam is plus minus. There's really no profound evidence of hyperperfusion on the skin exam. But the brain exam is very, very concerning. And so what do we do with this disconnect? Do we say the blood pressure is real because I see evidence of consequences of that blood pressure because of encephalopathy? But then you have to reconcile that with the skin manifestations of the lack of evidence of skin hyperperfusion. But whenever you're in doubt, you have to treat this as real. And shock ultimately comes down to one of four categories. Is the patient not perfusing because they're profoundly vasodilated? Distributive shock. Is the patient hyperperfusing because they have no volume to perfuse? Hypovolemic shock. Is the patient profoundly hypotensive because there's a blockage somewhere, obstructive shock, like PE, tamponade? Or is the patient not perfusing because there is cardiogenic shock or something wrong with the heart itself? And when you look over that heart rate, you see a heart rate of 46, you have to wonder if the heart's the problem here and that this person has advanced symptomatic bradycardia. The problem with that is many people walk around with a heart rate of 46 and have a completely normal blood pressure. So that's a little, that's a tenuous connection, especially when the jugular venous pressure isn't so high. So the evidence for the heart is that the heart being the cause of the blood pressure is that the heart rate is low, that the patient has crackles, the patient has edema, but what weakens that hypothesis is the jugular venous pressure is essentially normal. So here, welcome to real life. Evidence for cardiogenic shock, plus minus. Evidence for distributive shock is also not very prominent. The problem is that you always have to assume distributive shock is at play because it accounts for 70% of all shock. So no matter what data you collect, you have to worry about it because 70% of the people have it. No fever makes it less likely. The lack of a wide pulse pressure makes it less likely. And there's really no evidence on the skin exam with warmth to prioritize that, but you have to think about it. Is there evidence of obstructive shock? Not so much. The JVP is usually elevated. Is there evidence of hypovolemic shock? A patient's been vomiting and not eating well for a month. Almost certainly, that's it. Almost certainly there's a contributor of that. So where are we? We started with the assumption that this is a month log syndrome that now features the brain and the vagus nerve in the form of nausea and vomiting. And what we found is we got to get an answer quick. This patient is bradycardic and hypotensive and has signal to the lungs with the hypoxia, the crackles, signal to the heart with the bradycardia, edema, and crackles. And we have to clarify all these things. But first things first, give this patient fluids and then begin to understand what the laboratory signature of this disease is before you start making progress. Yeah, I'll leave it at that for now. Kirtan, give us more, please.
All right. Yes, so you are on the right track, actually. Amazing thoughts. All right. So the hemoglobin was all right. The WBC and platelets were fine. The sodium was 130. The potassium was 6.53. The chloride was 92. The bicarb was 15. The BUN was 40. The creatinine was 12.60. So 12.60, 12.60, with her baseline being 4 mg per dl. And the PCO2 was 30 millimeters of mercury. The liver enzymes were normal. The CRP and ESR was fine. The thyroid function test, vitamin B12 levels, HIV, HBsAg, HCV antibodies were negative. The complement levels were fine. Given the extremely high creatinine levels, our team was concerned about possibility of RPGN. So they did the urine analysis. The urine analysis was negative for proteinuria, RBC cast or WBC cast, or even muddy brown or granular cast. The ANA and ENCA panel was negative. And we did some imaging studies. So the echocardiography revealed the ejection fraction of 40% with normal wall motion. The chest X-ray was revealing for lower lobe haziness consistent with the pulmonary edema and the bibasilar crackles that we heard on the examination. And so Ravi, this is all the information. And then I will show you one final set of images. And then that's the end. That's all the information that I have.
What a teaser. What a teaser. Boy, my favorite organ, the kidney. You know, I may come across as being inconsistent about my favorites because 2 weeks ago I told you my favorite organ is the liver, and that's true. But my favorite organ is whatever we happen to be talking about today. Remember we talked about how a creatinine so high implies that the kidney itself has to be involved. So when we think about kidney issues, we think about pre, intra, and post. And the idea is that the kidney may be dysfunctional, not because the kidney is the problem, but because the plumbing to it, the vessels, artery and vein, are diseased. And that's, you know, in patients with congestive heart failure, often have congestive nephropathy or overdiuresis as the cause of their kidney issues. And here the creatinine being that high at 12 rules out pre-renal as the sole contributor of the disease. Post-renal disease is usually BPH in men and malignancy in women. And here you have to wonder, are you dealing with a retroperitoneal pelvic pathology that's causing kidney dysfunction, causing hydronephrosis, and causing uremic encephalopathy? So pre, unlikely to be the sole contributor because the creatinine's too high. Post renal disease is very possible because post results in kidney dysfunction itself. And in women is usually malignant. Okay. So could this be a subacute pelvic malignancy that's been lingering for 1 month, causing acute obstruction of the bilateral ureters, resulting in intrinsic kidney compromise, resulting in uremia, resulting in encephalopathy from uremia? Very possible. What about intrinsic renal disease? We divide intrinsic renal disease into glomerular diseases, tubular diseases, interstitial diseases, and vascular diseases. The urinalysis is primed to study the glomerulus. The UA is primed only to study the glomerulus. Why? It looks at the presence of albuminuria or proteinuria. And here, the lack of albuminuria and proteinuria makes glomerular disease very unlikely. What about tubular disease, interstitial disease, and vascular disease? Most tubular disease shows up as muddy brown casts. And so the lack of muddy brown casts makes that less likely. Interstitial disease can sometimes be very silent and not have any profound clues on urinalysis and may require a kidney biopsy for confirmation. The same is true of vascular disease. What are interstitial diseases? Most interstitial diseases are the abnormal reaction to medications in the form of interstitial nephritis, but may reflect a variety of disease processes, like crystal accumulation in the kidneys, like calcium oxalate nephropathy and ethylene glycol, may reflect the accumulation of heavy metals like lead and arsenic, may reflect the development of genetic diseases like ADPKD and sickle cell disease, so on and so forth. May be reflective of esoteric infections, some of which are Kushal's favorites like leptospirosis. And then vascular disease. Vascular disease is usually things like cholesterol emboli, scleroderma renal crisis, PAN, so on and so forth. So what do? We got to take a picture of the kidneys to see is there evidence of obstructive disease. Probably hydrate the patient and see what happens to the creatinine. And at the same time, be open to the occult mimickers. And the occult mimickers are microangiopathic hemolytic anemia, which is unlikely given the normal platelet count. Platelets, pigment. So checking a CK here is going to be very important to make sure this patient has not had rhabdo. Paraprotein. Could this person have multiple myeloma or a paraprotein-related disease process that is causing subacute malaise fatigue, now has plummeted kidney function and causing the syndrome before us? And then pointy things. So the 4 Ps are the things you always have to keep an eye out for. Platelets, signifying MAHA, paraprotein, multiple myeloma, pigment, rhabdo, and pointy things, crystals. Well, crystals, people can ethylene glycol toxicity, as we alluded to earlier, calcium phosphate toxicity from Fleet's enemas, so on and so forth. This case is tricky. It's tricky because you could assume now that the kidney is causing it all, but here's the problem. Most people with intrinsic or post-renal disease are hypertensive, not hypotensive. They have a drop in their GFR and their blood pressure goes to the roof. So we're in a tricky territory here because it's hard to prove that the kidney is driving all this because most people with uremic encephalopathy are hypertensive. How could that hypothesis be true? Partially true, where you could get uremic disease causing all this, but then the patient have a uremic pericardial effusion that's causing hypotension, or a uremic pulmonary hypertension. That's in one way. Or it's to say, hey, no, the kidney is actually just a bystander. It's not the driver of all this. In which case, studying the K may be important. And whenever you see a K this high, it's important to pin it on the kidney, to look at the meds like losartan, but also to wonder about the possibility of adrenal insufficiency, which you may wonder, well, wait, Tiago taught us that most adrenal insufficiency, especially if primary, causing this hypotension is accompanied by hyponatremia. And that's true, but remember that in patients with kidney dysfunction, their ability to excrete free water is limited. So that may be on account for why the sodium is a little bit higher. Where are we now? We're in nebulous territory. We need something to help us say, this is the thing that's going to guide me to the answer. The brain may be on the hook but it seems less likely with a creatinine this high and the medications being on board. The kidney may be on the hook, but it seems less likely because the patient's hypotensive, and most patients with intrinsic renal disease are hypertensive. The K may be on the hook either as a result of adrenal insufficiency or the effects of a toxin like digoxin that may be surreptitiously being used. But that could be easily explained by the kidney. So where do you go? You're like, all these things are not definitive towards the answer. So what happens in cases like this in real life is you wait for data to come to you to help you try to define the syndrome, but you have to stabilize the patient. What is the EKG? Is this patient in 3rd degree heart block? What is the blood pressure with fluids? And I think those are probably and then what is the state of the brain? What is the state of the kidney with a retroperitoneal pathology potentially? Those are threads that I'd be very interested in watching. All right, Kirtan, back to you.
All right. So now just to answer some of the questions which were there in the chat. So the calcium and the magnesium levels were normal. We did the USG thing. So USG was negative for any evidence of obstruction. And as I said that the urine analysis was already clear. So there was no oliguria. So even after the fluid resuscitation, things didn't help much. So the BP stayed the same, electrolytes stayed the same. There was no major difference there. And as for the anion gap and gamma back, so if you calculate the sodium, chloride, and bicarb levels, then there is evidence of high anion gap metabolic acidosis. But apart from that, the albumin and globulin levels were within the normal limits. So the gamma gap was not there. But from the calculations, we can make out that there was evidence of high anion gap metabolic acidosis. And the respiratory compensation was appropriate. So the CO2, the PCO2 of 30 was all right. And now I would like to share my screen and ECG.
One thing, my friend.
Yes. Yes.
I did not realize that there was an anion gap metabolic acidosis. I apologize.
Yes, sure. Yes.
How high was it? Do you have the number with you? What was the anion gap?
Yeah, I mean, I can calculate it. Let's see, 92 plus bicarb level, 92 plus 15, so 02. So around 24, I guess.
24. So the anion gap is about 12 more than we expect it to be. And so the question is it lactate or ketones or uremia? And I would say that those are possible. We don't have a lactate or ketones, but I assume the UA was negative for ketones, and maybe the lactate is a little high in a patient like this, but I don't know where this case is going to go. But in a case like this, where you have a high anion gap acidosis and you have marked kidney dysfunction, you have to make sure there's ethylene glycol is not part of the process. So this is a case where if the lactate is not impressive and does not account for the anion gap, you would definitely be open to getting serum osms, looking for an osm gap, and maybe even empirically treating the patient with fomepizole pending that data. I heard you say the words EKG, which make me move away from ethylene glycol, but practically speaking, we had a case from Steph Sherman, and ethylene glycol is this is a presentation that is very consistent with it. So keep that in mind. All right, Kirtan, back to you.
And I'm sorry that I don't have the lactate levels, but as I told you that this was a case of emergency department, and given her electrolytes and status, we were so furious that we didn't get time to draw much of the level. Yes. But I guess ECG, ECG will show you clear evidence.
Yeah. Okay. Sounds good. All right, let me, you're close, so you can share the screen whenever you like.
Yes. Can you see it, Rabi?
Sorry, I can see it now. And when I first starting to look at lead 2, because I try to identify this, I find that to be the greatest lead to look for whether or not there's sinus rhythm. I see a QRS complex and a pretty normal QTC. It's less than the RR. I don't see any marked. I don't see any marked ST elevations. I'm trying to figure out what the rhythm is. I don't see a clear P wave before the QRS, so I strongly doubt whether this is sinus. But I'm looking closely because sometimes the P wave can be so small. We know that potassium is 6.5, so I'm biased to looking for manifestations of hyperkalemia with peaked T waves, which I don't see. But the bradycardia itself along with potential widening of the QRS depending on what the patient's baseline is, may be suggestive of it. At the end of the day, I'm also my mind is gravitating towards leads 2 and 3's very interesting appearing ST segment. It looks funky, for lack of a better word. It looks scalloped, not to the degree that we often associate with marked digoxin toxicity. But if you look at AVF, the for SD segment in AVF. Oh, sorry, one sec. No, don't do that. My dog is chewing on my heater. Always a bad idea. Yeah, so I'm gonna actually pass the mic to you, Kirtan, for your analysis. What I see is I think there's a junctional rhythm. I'm not sure what the state of the QRS is. I'd be worried about some manifestations of hyperkalemia. The ST segments look funky to me, especially in lead 3 and AVF. And I'm probably missing things because EKGs are not my forte. But I will keep studying it and look for your learn from your how you interpret it.
Yeah, so I have 2 more ECG images, other leads, maybe that can help you. Okay. So, all right, let's go. Yes, so this is the second image.
So here,
hey, Robbie.
Yeah, yes, sorry. Yes, Travis.
Oh, I was just going to say, looking at the height of the T wave compared to the QRS, is always an ominous thing. One with ischemia and 2 with hyperkalemia. That was kind of the first thing that jumped out.
No, I completely agree. I think especially in lead 3 now, the T waves are definitely jumping out at you, and you'll learn about how big the T wave is. So broad-based T waves can be indicative of ischemia versus the peak T waves of hyperkalemia. Here, the breadth of the T wave is actually very alarming and maybe suggestive of ischemia. So what are we seeing here? I think we are seeing manifestations of hyperkalemia on this EKG. And the question is there anything else that I see? I don't know. I would say that people will tell you just study for in a patient with hyperkalemia to study the possibility of concomitant dig toxicity. And I don't know if the ST segments can be evocative of that too. But I think what would I do in real life? I think this patient needs calcium gluconate stat. And a troponin would be very, very helpful. If you look at V2, that ST segment in V2 looks elevated. So you want to make sure that that could also be a manifestation of hyperkalemia. So where are we now? I think tricky EKG, quite honestly. Rhythm is probably a junctional escape because there's no native P wave activity. There's almost certainly evidence of hyperkalemia manifesting on this EKG. And the question is there anything else going on? And the thing that can sneak in is digoxin toxicity, whether or not that's prescribed or it's plant-based. So I think calcium is something I would definitely consider doing, a troponin for ischemia, given those T waves. And then talk to cardiology experts or Kirtan to see if DIG may be involved somehow. All right, Kirtan, back to you.
Yes. All right, so Ravi, do you want to give us the final diagnosis? Because now the aliquot which I'm about to share will reveal the answer.
I gotta say, I don't know. I think that, I don't know. I would, in real life, I don't think I would have confidence about what the final diagnosis is. So I'm really looking forward to learning from you. I would say that there's enough. I'm curious if the chat. I'm just open the chat right now. I'm curious if the chat has any specific final diagnoses. I know I wouldn't commit to anything right now. Honestly, I'm really looking forward to learning from you. And I think I would worry about digital. I think hyperkalemia alone is a good place to start as a driver for this. Why the kidney is, if we assume that the K is causing the cardiac issues, we then have to ask, well, why is the kidney so diseased? And why is the kidney so dysfunctional? And that often that explanation is unsatisfactory because a profound hypotension can cause kidney dysfunction, NOS, resulting in these manifestations. So what are the things that I would be wondering about? I'd be wondering about ditch toxicity because of the disproportionate hyperkalemia. I'd be open to the possibility of ethylene glycol toxicity causing the kidney dysfunction. And that's it. That's all I got.
All right. Yeah. So now for the official EKG read, the official EKG read goes like this, that there is evidence of bradycardia, there is evidence of P wave flattening and probably prolonged PR interval, but difficult to interpret because of the flattening of P wave. And also there was scarcity of the signs of hyperkalemia. I mean, given the degree of hyperkalemia, we should see have more evidence of hyperkalemic changes, but there was not drastic changes. So that was one thing. And talking about the final diagnosis. So now this is my favorite part. If not for the human diagnosis app, I would have never figured it out. So it was, kind of deja vu for me. So back in December, this case was published. Similar case was there in human diagnosis app. And then in the Medscape on February 1st, a similar case was published. And so I even read that. And this is a case on of 7th of February. So everything was fresh in my mind. And then I suggested my team that it may be what is known as the BRASH syndrome. So BRASH syndrome. So it is a combination of bradycardia, renal failure, AV nodal blockade, shock, and hyperkalemia. And the peculiar thing about this syndrome is that usually we know that when the hyperkalemia causes bradycardia, the hyperkalemia needs to be so high. So like, let's say potassium is of 7.5 or 7.8, then that can cause bradycardia. But the potassium of 6.4 is not high enough to cause bradycardia. And again, the thing that you mentioned on and on, that we should usually see hypertension. But the fact that we are seeing profound hypotension makes this BRASH syndrome extremely likely. And the reason is that because the patient is on ACE inhibitors, so losartan, the losartan itself can cause hyperkalemia. Then losartan can even cause hypotension. The patient is on labetalol. So labetalol being a non-selective beta blocker. So even if the patient had been on carvedilol, it would have been same because both of them are non-selective and they would have affected the AV node. They would have affected the potassium levels. And once the renal failure occurs, there will be hypoperfusion. So it's a vicious cycle. You can't get out of it. And the final thing was that, as I mentioned, that given the profound changes on ECG, which we would anticipate, they were not there. On only thing which was jumping on ECG was bradycardia. Apart from that, everything was fine. So it was again suggestive of the BRASH syndrome. And as you mentioned, we provided the calcium gluconate. We immediately started the patient on hemodialysis to make sure that potassium levels are under control. And we stopped the ACE inhibitors, we stopped the beta blockers, and it worked like magic. So when I examined the patient next day, the patient pulses were back to 80 beats per minute, blood pressure was 110 over 72, the ECG changes completely resolved, and the latest potassium levels was 4.9. So without doing much, it all resolved on its own because of stopping the medication. So thank you to Travis and everything for that human diagnosis case. If not for that case, maybe I won't have figured this out. So I suggested to my team that it was due to Ravi and our team that I was able to figure it out. So thank you so much for that.
What a wonderful case. I'm just beaming here. This is so amazing. Thank you so much. But I want to take one opportunity because as soon as I pass the mic to you, somebody in the chat mentioned the idea of BRASH. So Sherry, if you're in a position to unmute yourself, please tell us more about how you got to this analysis. And I'll then ask Kirtan to reflect a little bit more. But Sherry, tell us what you were thinking. I see that you've unmuted yourself. I don't know if your mic is working, but we can't quite hear you. Oh, there you go. Hello. Hi.
Can you hear me now?
Yeah, we can hear you now. So tell us more about what you were thinking.
I had the fortune of taking care of a patient who had BRASH syndrome a year ago on the ICU service. So that's why I kind of remember the patient had bradycardia and renal failure. So that's how it came to my mind.
Yeah, wonderful, wonderful. You know, I'm just so inspired by both of you, Sherry and Kirtan. Both of you are stepping into the role of being an official primary provider. Some of you have gotten your MD, some of you are waiting for it, but both of you are in a journey to just begin independently caring for patients under supervision. And it's incredible how both of you are like both of you were like, oh, I heard of this or seen this somewhere, and it just and it really struck with you. And I think it's humbling for me. I've never seen a case of this. I've read about it, honestly. It had completely escaped my mind, even though I have, I've come across a couple of blogs. I don't think I've read a case, but I think on Twitter, somebody had posted about it recently. So I'd heard it before, but it definitely didn't register in real time, as you all saw. And I'm humbled by the power of having seen it directly before your eyes or having seen it virtually, as Kirtan did. And I will sit back. I have a lot to reflect on and learn and grow. This will certainly be a source of a lot of reflection and recalibration and a lot of learning. I honestly tell you, my cognitive autopsy, I was so fixated on digoxin because of the degree of nausea and vomiting and encephalopathy being a marker of DID. So like if you were making a list of AV node toxidromes that cause bradycardia, I will now add BRASH to it with the prominent clues being the profound hypotension, which you would not expect you wouldn't expect hypotension in digitoxicity. You would expect actually a higher contractility. So this is so much learning for me. I'm curious, Kirtan, if you had to summarize now what you understand about BRASH syndrome, because you taught us about the pathophysiology, what happened to your patient, but what do you conceptualize BRASH syndrome as before we pass the mic to Andrea to do the teaching points?
Yes. So actually, the way you mentioned initially that the disease curve goes like this and then goes like that. So what was the trigger point? So interestingly, you mentioned it in the first aliquot itself that uremia can cause metabolic disturbances, uremia can cause nausea and vomiting. So if you think about it, the patient's creatinine was so high. So maybe that's what caused the patient's nausea and vomiting in the first place. And the dehydration due to the nausea and vomiting, and again, nausea and vomiting will cause hypokalemia. So that will again the counterbalance the potassium levels. So that will mess up the actual potassium balance. That was one thing. And that nausea and vomiting itself might have triggered all these things. And the mental status was due to uremic encephalopathy. So probably all of this was brewing since quite some time, but the nausea and vomiting was the tip point. Once that happened, the ACE inhibitor and everything prevented the renal compensation that should have occurred. And given the compulsion that cardiac thing should have done, but since we were on beta blockers, we can't accelerate the heart rate and we can't control the perfusion. So that was the reason that it's basically contribution of all the things. And that's why BRASH syndrome is important, because if we target only one entity, the patient won't be treated. We have to target all the entities simultaneously in order to get out of the vicious cycle. So that was my take home point. What do you think, Rabi? Do you have anything to add?
No, that's beautiful. I have to learn a lot from conceptualizing it. And I was opening my Evernote because I'll just put it in the chat. I found the tweet that I was going to read. I didn't actually. I just put it in my notes. I didn't delve into it. But here is a tutorial that I have bookmarked. I haven't read it yet for BRASH syndrome that I think we should consume. And Kirtan, if you have that human DX case, maybe you can paste it in the chat or let us know about it later so we can review it. But here's a really great tutorial about BRASH syndrome that I had bookmarked. But thank you. That makes a lot of sense, and it goes to show the role of multiple medications, including the ACE inhibitor in this case. Thank you so much. I'm humbled. That's going to be a great Friday reflecting on this case. All right, Andrea, do you want to take us home from the beginning?
Yeah, it's an amazing case. I learned a lot, so I'm happy to celebrate another year learning something. Something new. Well, we started, sometimes when we have a patient that have signs that are debilitating, like in this case, the patient had nausea and confusion, we tend to assume it is acute, but it's not always the case. Nausea and vomiting are triggered by the vagus nerve, and there is not particular anatomy, as Ravi said. Since it innervates us from the head to toe. In the case of altered mental status, like this patient, we think about the mixed mnemonics, with MIT being the extra outside the brain, which is metabolic, infection, or toxin. We were thinking maybe this was an hyperacute case of altered mental status. In those cases, we always think about stroke, seizure, or hypoglycemia. But for example, when we have an altered mental status that has focal features or is very deep, many times it is in the brain. And we were thinking whether it was something abroad or something that was slowly progressive. And because she had a hair signal in the heart, we thought about possible causes like digoxin toxicity, embolic disease, ischemic heart disease, plant-based diets. An example of something slowly progressive was like the perfusion that grows enough in a month to cause a cardiac tamponade. So when we saw the blood pressure of this patient that was 70/40, we begin to think, is this number real? So we have to correlate with the signs of the patient to look at his skin and see if this number is real. And in this case, treat as real. Something that we always had to know is that the distributive shock is that type that's the 75% of the cases. So always keep it in mind. So we also, then when we had the labs, we saw that the creatinine was elevated. So we talk about the possible causes of kidney dysfunction that can be pre-renal, like the plumbing, like in patients with cardiac heart failure, congestive heart disease, retroperitoneal masses that can be causing obstruction, post-renal, like normally in women tend to be malignant, and intrinsic that could be tubular, vascular, interstitial, or glomerular. In the case of glomerular, of interstitial kidney disease, it can be silent and not have many clues. May require a biopsy. We always think about interstitial. We think about the elderly person who takes pain medication every day. So it can be cause to medication, also crystal accumulation or cholesterol. We think about the 4 Ps, platelets for MAGA, paraprotein for multiple myeloma, pigment for hemolysis, and pointy for crystals. And finally, this new syndrome I didn't know about, that it was bradycardia, renal failure, AV blockade, shock, and hyperkalemia. And it's a synergistic process that created by the combination of hyperkalemia and medication blocking the AV node. And the most common precipitants are hypovolemia and medications promoting the hyperkalemia or renal injury. Thank you very much.
Ooh, another incredibly memorable Friday. Thank you all. Thank you, Kirtan, for an amazing case. Andrea, happy birthday. Thank you for doing the teaching points on your birthday. And everyone in the chat, it's just, I when I'm discussing solo, unlike when I'm going with Reza, it's really hard. I actually don't look at the chat. It's too hard to keep track of, but I just love the comments coming through, especially Tiago's comment. I'll read it out loud so everybody who watches this later can hear it. It says from Tiago, our beloved endocrinologist from Brazil, if I had read BRASH 1 hour ago, I'd say it's a typo of brush. And with that, I'll say goodbye.